Hello, everyone. Thank you. My name's Phoebe. So I am a project officer and a social worker with the Restrictive Practices Unit. So I'm relatively new, started in August last year. I've got my lovely colleague Nicola in the back corner of the room as well. She'll be monitoring the chat for our online attendees. So any disability service providers in the room, you may have spoken with me via our duty phone service. So that might have been where you've heard my annoying voice. And we try to provide some helpful general advice to you guys via our duty service. But today it's not so much about us. We've got the lovely Connie Wu with us here from the Victorian Senior Practitioners Office, so our equivalent of the RPU over in Victoria. So I'll introduce Connie. She is a consultant pharmacist by training with experience in public health, policy and government regulation. So she's currently working as a clinical consultant at the Victorian Senior Practitioners Office. And today she'll be sharing some findings from a deprescribing project. So this was focused on a multi-D approach to reduce the use of psychotropic medications for people with intellectual disability. So just a couple of points. We'll have some time for questions at about 11:45. So perhaps if you've got some thoughts happening, jot them down, and we'll be able to have a chance to ask Connie some of those. The session will conclude formally at 12, and there'll be no sort of closing address. So we'll have a little QR code up there for feedback, and we'll just ask that you pop your lanyard in a box by the door, and then you're free to go on your way. So if you do have any questions, it will be a great time to ask them, and anything outstanding, contact us and we'll get in touch with Connie. But I will hand over to the lovely Connie Wu. Thanks, everyone.
Thanks, Phoebe. Hi, everyone. I'm Connie. Like Phoebe mentioned, I'm a consultant pharmacist by training, and today I'll be talking about the project that our office has funded that we've been doing for the last 2 years, looking specifically at deprescribing the use of psychotropics in people with intellectual disability. Before I start, I would just like to acknowledge the traditional owners of the lands on which we're meeting today. That is the Kaurna people here in Adelaide CBD, and pay my respects to elders past and present. So as we heard this morning, the use of psychotropic medication has been quite topical recently. We've got the joint statement released by the three commissions a couple of years ago, highlighting that psychotropic medications are overused or overprescribed in people with an intellectual disability and the older population, and that it is a quality and safety issue in our healthcare. So some of the key concerns highlighted were that people with an intellectual disability are at higher risk of displaying behaviours of concern, and those behaviours can lead to issues with social participation, and there's a direct linkage to the overprescription of psychotropic medications, in particular antipsychotics, and that's supported by the data that we collect at the office as well. We know there is a lack of evidence for using psychotropics in this manner, but we have very good evidence of harm, particularly with long-term use of those medications. We also know that everyone has tried really hard to reduce the use of psychotropic medications in this population. I'm sure that those of you here today have probably tried yourself to reduce some of the medication use in the participants you work with. However, there's a reason why we haven't really been able to make a big shift in this space. In Victoria, from our office, we started collecting data on the use of restrictive practices since 2007, since our Disability Act was enacted. And over that time, we saw the use go up, not down. Now, some of that can be explained by the fact that the sector's more educated around the medication use and are able to more correctly identify chemical restraints. But that also doesn't explain why, overall the numbers, we're just not seeing a reduction despite multiple education campaigns and multiple projects. So we know that there are a lot of systemic barriers that everyone faces. So I've listed some examples here. So the first one is the definition of chemical restraint. We have to understand that prescribers' view of what a chemical restraint is perhaps very different to the definition we understand it as under the NDIS rules. So, for example, in Victoria, chemical restraint in the mental health space has only recently started to be regulated since 2022. And that definition in the Mental Health and Wellbeing Act really only is restricted to rapid tranquilization. So the definition under the NDIS rules is much broader, and that probably explains why sometimes when you are discussing the issue of chemical restraint from the prescribers, you get a very strong reaction because that's very much what they are familiar with. Obviously, we have communication barriers that can be the participants themselves, for example, being nonverbal, but also between different care providers. During transitions of care, we know that communication can be quite poor. For example, during hospital discharge, often medications that are intended for short-term are continued ongoing because that information is not shared with the primary care providers. There is also the issue of diagnostic overshadowing in that some behaviours or presentation of symptoms are attributed to the person's disability and the underlying cause is not properly explored and managed, and medications are used to mask those behaviours. The monitoring in general of psychotropic medications is quite lacking, both in terms of efficacy and side effects. That probably links to the fact that support workers are generally not trained in medicines, and the side effects of medications there's a huge list, and it can be quite difficult for support workers to correctly identify them and then communicate that with the prescriber. And then in terms of efficacy, often we hear that no one within the care team is actually aware of why the medication is being prescribed in the first place. So how can they be monitoring whether it's actually achieving its intended purpose? We know that there's not a lot of collaboration currently between the prescriber and the rest of the care team, certainly with the behaviour support side. And there are larger issues such as service gaps. So the biggest one is probably the limited availability of psychiatrists, certainly the dual disability psychiatrists. So all of these issues contribute to the problem that we're facing today, which is an overprescription of psychotropic medications in this population. So with our project, we really wanted to address some of those barriers that we know that the sector has been feeding back to our office very strongly for a number of years. So we wanted to promote a multidisciplinary model of care to try and reduce the use of psychotropic medications in people with an intellectual disability. So some of the key objectives were we wanted to increase the knowledge in the support staff around the basics of medications, basic principles of positive behaviour support, the limitations to medications and alternatives to medications. We also wanted to upskill GPs' knowledge in this area through educational visits. As we heard this morning, this concept of deprescribing, it's quite new to prescribers as well. And even the evidence base around how psychotropic medications are used to influence behaviours, because it is an area that is lacking evidence. So a lot of the GPs are actually unsure about how to proceed. And also GPs are not aware of what's happening with behaviour support and what the behaviour support strategies are. So those are the areas we wanted to cover with the GPs. One of the key outcomes we wanted to come out of this project is to develop a high quality fade out plan for chemical restraints. Currently within the behaviour support plans, the fade out plan for chemical restraints quite brief or limited or non-existent in some cases. And that's not surprising because the decisions around medications rests with the prescriber. So without the prescriber's input, it would be really impossible for behaviour support practitioners to draft a fade-out plan. So we wanted everyone to work together to come up with a fade-out plan that's got a detailed reduction schedule for the medication, as well as corresponding response strategies to manage some of the potential escalations in behaviour or withdrawal symptoms. And then we obviously wanted to assess the impact of those interventions by monitoring how the person is functioning and their quality of life. So the few components for this project, so one is training to the provider organisation. We did open the invite to anyone within our partner organisations, so all the support workers and the health supervisors definitely came to the training, but we also had behaviour support practitioners, some of the senior managers from the organisations come along to the training. I'll touch on the training itself a little bit later, but it's two 4-hour sessions on two separate modules. The pharmacist we engaged is also an experienced GP educator, so she visited the GPs before actually conducting the medication reviews, and it was a 30-minute session to discuss anything the GP may be interested in around this topic. Generally, it is around how to prescribe safely. When we started this project, the Mosleys guidelines wasn't published yet. So there was not a lot of guidance around for the GPs. So some of the other areas of interest were side effect profiles, withdrawal symptoms for each of the different types of medications, as well as the basics around positive behaviour support. And we also wanted to make the GPs aware of the training we've provided to the service providers. Then the pharmacist conducted medication reviews for each of the participants, paying particular focus to look at the polypharmacy related issues. So that would be the side effects, the drug-drug interactions, and then really trying to work backwards, looking through the history and speaking to the families and the carers around the intent of each medication, and sometimes that was impossible to find. And then formulate a plan to look at how to rationalise that very complicated medication regimen and come up with some recommendations about how to reduce them. Once that plan was developed, there was a team meeting with everyone in the care team, so the behaviour support practitioner, the health supervisor, the pharmacist and family members, if they wanted to be involved, to discuss the recommendations that's done by the pharmacist and agree on the plan going forward and what would be presented to the GP. And then the GP will review the recommendations and decide whether or not to proceed and how to proceed. And any changes were then implemented. So Spectrum training stands for short-term psychoeducation for carers to reduce over-medication in people with an intellectual disability. It was developed by Professor Deb in the UK, who graciously shared all of the resources with us for this project. So we only deliver the training on the two core modules. The first module is around the basics of medications. So we went through what the different classes of medications were, what the side effects were, what the withdrawal effects would be. And then the second module is on alternatives to medications, and it's basically a brief overview of all of the positive behaviour support principles. So we ended up having 3 partner provider organisations, and like I mentioned, all of the support workers that were directly working with our participants did attend. We also had 3 mums attend, which was really great and added to the conversation. And then we asked participants to complete some questionnaires just to gauge whether there's been any change in their knowledge after the education sessions. I won't go through in detail what the results were, but suffice to say that overall there's an increase in the knowledge of medications around why they would be used and how they work. and definitely an increased awareness of what the side effects are for each class of medications that are used. And in terms of the attitudes and beliefs around the management of aggression or behaviours, the trainees were generally more strongly agree with the fact that environmental factors contribute to behaviours, and that communication and relationship with the participants can also influence the behaviour, as well as skill building. And at the end of the session, that trainees would generally agree with the fact that medication shouldn't be the mainstay management strategy. With the GP education sessions, so the pharmacists provided tailored information depending on what the GP's interests were. We had 8 GPs in total, and only one GP has ever read a behaviour support plan out of the 8, which is not surprising, but all of them have said that they are interested to find out more about what's happening on the behaviour support side and that they don't get enough information. And then the other key points of discussion is really around how to deprescribe and how to do it safely, and what supports are available to GPs if they want to go down that path. So the medication reviews, in the end, we were able to recruit 9 participants. We initially hoped to recruit to 30 participants, and we had 5 big national service providers who were willing to partner with us, and we tried very hard, almost 12 months of active recruitment. So the biggest barrier was really the families and carers not being comfortable with the idea of making any changes to medications. Often that's due to past negative experience. I'm sure you've all heard of experiences where medications were halved or stopped overnight and the person really reacted quite negatively to it. So there is that fear of destabilisation. So unfortunately, we just had to proceed with the 9 participants. And it was very evident during our training sessions and subsequent conversations with the families and carers that those 9 individuals all had very close relationships with the current team around them, which probably explains why they were able to give consent, because we did ask the health staff to speak to the participants and recruit. So there's a lot of trust and history that's really quite critical to take this step, because it is a risk. Any change is a risk. So the pharmacist then reviewed all of the medications and looking at whether the medications were still clinically indicated based on the information that she could gather, and any observed side effects, and then the recommendations around reduction. So she actually did do a table of gradual reduction with all the doses worked out week by week for the GP. And we asked the behaviour support practitioners to collect baseline data around behaviours using the modified overt aggression scale and a quality of life scale. That's just for our evaluation purposes. Obviously, the behaviour support practitioner will still do all of the monitoring that he or she would normally do, such as sleep tracking and appetite, mood, all of that. So once the medication reduction plan was developed, the whole care team met to discuss the recommendations. And this is very critical because this attempt to reduce medication, it involves everyone in the care team. So everyone had to be on the same page, otherwise it's not going to work. So the order in which the medications were reduced really were dependent on a few factors. So looking at the efficacy, sometimes it's very clear. We have information from the care team that a certain medication has had no effect on the person whatsoever since they were started. Or if we're noticing significant or obvious side effects from certain medications, Sometimes the order in which we chose the medications were tweaked after the meeting based on information from the care team or the families, because they've had past experience with reduction of certain medications. Essentially, we wanted to start with one that's least likely to cause destabilization, so that everyone can get comfortable with the idea. I should say that we did focus our recruitment on people with polypharmacy, so multiple long-term psychotropic medications. So out of all the participants, the recommendation was to reduce 2 or more of the psychotropics from their current regimen. We were also lucky enough to have the support of the Victorian Dual Disability Service, which is a statewide dual disability psychiatry service based out of St Vincent's Hospital in Melbourne. So the clinicians there reviewed the reduction schedules and the recommendations before they were passed on to the GP. And most of the time, the feedback was to slow down the reduction rate even more. So at the end of the last year, we were able to evaluate the 6 months mark of our project. So that's post the medication review recommendations being passed to the GP. So 8 out of 9 participants actually did reduce their medication. Only one participant had their medication reinstated to the previous dose because of withdrawal symptoms, or what we presume to be withdrawal symptoms. The care team, the behaviour support practitioner and the support workers with that participant were actually quite happy to manage that without increasing the medication, but the GP was really uncomfortable with what she saw in terms of the changes in that person. And the other 7 participants actually had minimal withdrawal effects. We had one young male who did have quite severe sleep disturbance for a couple of months, but then that settled, and the care team was fantastic in really supporting him and putting extra staff over that time overnight to get him through this period. And the participant who didn't have any medication change actually did move house around the time that we did the review. So it was decided that it's best to put off any changes until she's settled in her new home. So we'll be in contact with the GP this year to discuss how to proceed from here. In terms of the medications targeted, so 5 participants had their atypical antipsychotics reduced. We know from our data that antipsychotics by far the most commonly prescribed chemical restraint, so that's not surprising. 1 participant had anticonvulsant reduced, and I should say that all the participants we've recruited do not have comorbid mental health or physical health diagnoses for those medications. So we were confident that the medications we were reducing definitely considered chemical restraint under the NDIS rules. And 1 participant had their antidepressant reduced. Like I mentioned before, that decision is made by the whole care team and had everyone's support, and that was really important. So this result was actually better than what we anticipated, to be honest, that the vast majority were able to reduce their medications in some degree. And some of the enablers for success were that the whole engagement of the entire care team, including the families, was really helpful, particularly in addressing some of the concerns early on. So during our training sessions and subsequent conversations, mostly the concerns were revolved around potential withdrawal symptoms or re-emergence of behaviours and how to manage that. The fact that the behaviour support practitioner worked really closely with the care team to come up with the response strategies did provide that reassurance. But I think just the awareness by the whole care team around what to expect, that, you know, withdrawal symptoms are possible and this is what is likely to happen and this is how long it may last, that alone was able to alleviate some of the concerns. For the GPs themselves, because we did get consent from the participants or their families initially. So when we visited the GPs, when they knew that the families and the participants had already given consent, they were on board with at least giving it a try. I think their biggest fear, based on our conversations with them, is that they don't want to destabilize the patient and they don't want to be blamed should anything go wrong. So that reassurance from the families and the participants and the care team, the fact that we know there are backup strategies available to the care team, that medication is not the only option, and the fact that we had the dual disability psychiatry service available for further support, they all help to give the GPs confidence to give it a trial. We also managed to interview most of the GPs. I think we've got one more left to interview just to gain some understanding around their experiences with the project and the reduction process. So GPs noted that often medications are prescribed for a long time. They're generally inherited patients, so it's really difficult to ascertain what the initial intent for each medication is. They've all emphasised the importance of communication and collaboration, but at the same time acknowledged that that's not happening and that's not helped by the setup of our current health system. The challenges of implementing gradual medication reductions definitely highlighted. As we've heard this morning, we don't even have commercially available products to be able to facilitate that process. And GPs were very adamant that if they were to trial a reduction, it had to be very slow and methodical to avoid any adverse effects. And that if adverse effects were to occur or behaviours worsen, they were very unlikely to continue to proceed with the reduction. And not surprisingly, they raised concern with the term chemical restraint. As I alluded to before, it's just a difference in understanding, a difference in definition that we just need to keep communicating around that. So the next step is to continue to progress with the reduction. So we've done our 6 months review. Given that we're only just past 6 months, we're still on the very first medication. Generally, for the reduction plans that were drafted for those participants, it would take 9 to 12 months at least for each medication. Again, as we heard this morning, that would probably go on for longer, but we will do another evaluation at 12 months and wrap up the project. But the care team will continue with that process beyond that. And we will also assess the impact on the participants at 6 to 12 months. So I guess at this early stage, some of the observations or limitations that we've noticed. So firstly, the significant amount of time required to review the medications for this cohort. We did recruit participants with polypharmacy and to actually work through all of the issues related, all the prescribing cascades that's occurred over many years takes a long time, and that's not always remunerated for anyone in the care team. And there really needed to be one key person who is able to keep track of the progress and monitor and feed that back to the prescriber. And that can be difficult in the current setting with the service providers. And once that person is identified, it does actually involve quite a lot of work to keep track of everything and all the information. So again, that's a burden to the providers, and the training, the providers did offer over 20 staff for 8 hours of in-person training. So it's quite an impulse on the providers as well. The dual disability psychiatry support is not always available. We only have one service in Victoria that's statewide. The wait list is very significant. They've kindly agreed to support the GPs who are part of this project, but all of our GPs would like support and we just don't have that service available. And the other request that's come through quite strongly from the GPs is they would like a summarised form of the response strategies formulated by the behaviour support practitioner. They're not aware of the other non-pharmacological strategies being implemented. They would like to know them. They would like to know their effect on their patients and how to work with them better. This all goes back to helping to inform the decisions around medications. I'd just like to also acknowledge our many partners. We are very lucky to have a very experienced steering committee and working group who bring a lot of their expertise and shared a lot of their time with us to inform this project, without which it wouldn't have been possible, including Professor Troller, who's next door. It's not an exhaustive list, but it just goes to show, I think, the amount of effort that's required from all different sectors to come together to try and make any impact on the use of medications. And I'll just also highlight that we have a new project starting this year in partnership with the Royal Children's Hospital, that's led by Dr. Daryl Afron, who is a paediatrician from the Children's Hospital, to look at the therapeutic monitoring of psychotropic medication use in children and young people, and the implementation of non-pharmacological strategies. And that includes positive behaviour support, OT, all of the allied health therapies, to really explore what are the current gaps in practice. We know that medications for psychotropic medications for people with intellectual disability are generally started very young. So it would be great to do some work in this space to try and make sure that only medications that are absolutely necessary are prescribed from that young age. But more importantly, all of the non-pharmacological strategies are optimised. So the editorial was just published, so feel free to have a read if you're interested. Thank you.
Hello. Okay, cool. All right, so we've got about 10 minutes for questions for Connie. And we have had a bit of trouble with our online audience, which is a real shame. So it's up to you guys now. I'm looking to whoever's in the room, if anyone feels kind of brave enough or has anything they'd like to share about their own experience. Mel?
Hi, my name's Mel Ingham. I'm from an organisation called Community Living Options and the PBS manager there. And I just want to, we do a lot of work with the forensic cohort, often lots of polypharmacy, often CTOs in place, that kind of stuff. But we also have a lot of resistance from our participants who don't like the feeling of having the medication that they take, often in injection form. But what I've noticed is that with the participants we see who go into prison, who often have to give up smoking, drinking, and all that kind of stuff, which I think they do sometimes to mask, and cope with other symptoms they experience, that withdrawal symptoms seem to be almost negligible, which I have found really fascinating, because I'll often visit our participants in the prison and ask who's, the people like the doctors and that, if they've been experiencing anything, because they might be, say, heavy smokers on the outside, and then they go in, they're not allowed to smoke anymore, and there seems to be no huge change. And I just wondered whether it's not that they're not experiencing symptoms, but the withdrawal symptoms look very different for them, perhaps because of their disability. And I wondered if that was kind of discussed, because we know that people, you know, particularly with intellectual disability, experience different physical things in their body. Their temperatures often run at a different level. They understand things very differently. And so I wondered if that was ever explored, or if there's any research around maybe different symptoms for people with disabilities that aren't seen in the non-disability participants.
So based on the participants in this project, the symptoms were definitely same as what's described in the evidence, but it might be the presentation that's different.
Yep.
So the one participant who did have her dose increased, the only presentation was really just dysregulation during medical appointments and self-harm during the appointment. So I think they're obviously experiencing discomfort, whether it's physically, mentally, or emotionally, and they're just expressing it in different ways. We did see, like I mentioned, a bit of sleep disturbance. You know, he was perfectly happy, but he was just up from 2 to 5 and he wanted to party for 2 months. So yeah, I think it's just any changes in their behavior pattern or in their mood or sleep or appetite as medications are changed, we can safely assume that it's probably got something to do with the reduction in medication.
It would be interesting then to engage in NDIS planners to see if you can have a change in funding for a period of time to support some of those, like sleep disturbances and the cost around that, to make sure the plans cover those kinds of things. That would be interesting to do.
Yeah. And I think the key thing is also that everyone is different. It's very individualized. We did have 6 participants who had minimal effects. It is a very gradual reduction, and most of them are actually functioning better, as you would after being taken off some of those medications. Yeah.
Thank you, Mel, for your question. Sarah?
Hi, I'm Sarah from Cara. I was interested to hear what you said about it taking a lot of work to sort of track the progress. And I think you were saying that the person responsible for that tracking was a support worker that worked directly with the participant.
That's right, generally the health supervisor, but I did support them as well. We had 2 GPs who wanted to have the secondary consults with a dual disability psychiatrist, so I helped facilitate that, as well as some of the conversations with the prescribers. And also information just gets lost. So, you know, if it was agreed that a medication is to be reduced, and we had an incident where 6 months later, everyone's forgotten about it. So it wasn't implemented until much later. And those things happen. Everyone's got a lot on their plate. So unless that person's sort of assigned from the beginning, it's very hard because everyone just assumes someone else is doing it.
Well, I was wondering what sort of methods that person adopted to sort of track, and whether there was sort of a formal tracking, or whether it was just something that was adopted on an ad hoc basis, dependent on each participant.
I think the team meeting initially, after the medication review was done, and the health supervisor would be aware of the recommendations being passed on to the GP. The behaviour support practitioner also knew what he or she needs to monitor for, and how we did discuss how to communicate that information to the GP in a very concise way. So then the health supervisor did know what information will need to be passed on from the behaviour support practitioner to the GP. And other times we've had the behaviour support practitioner prompting the health supervisor or myself to check how things are going. So it wasn't formalised, but I think that meeting initially, just to set the scene and have everyone be on the same page, really helped, because everyone knew what the plan was and who to contact for what sort of issue. So that was made very clear at the start. Thanks.
All right, guys, I think we've got time for 1 or 2 more. Does anybody else have anything they'd like to ask Connie?
Thanks. I'm Luke. I'm a behaviour support practitioner from Insight PBS. Did they come up with a method of shortening the BSP for the GP?
It wasn't the entire BSP, it was just the response strategies. Yeah. So all the behavior support practitioners did develop a one-pager of the response strategies, whether it's just escalations in general or if it's a withdrawal symptom. I guess, the response strategies were the same, and we attached that to the medication review. So the GP had all of that information in the one spot.
And is this project continuing? Because you only did it for 12 months or?
Yeah, so we will continue until the 12 months mark for all of our participants. We sort of staggered out. Some participants started the reduction earlier than others, but we will wrap up at 12 months and do our evaluation. That's not to say that the participants and the care team will continue with that reduction process post the formal evaluation part of our project.
Because we just heard that it's going to sometimes take longer than 12
It
months.
absolutely will, because at this point we're still not even halfway on the first medication. So the reduction itself will definitely take longer, but we can't continue to roll on. This project's already been going on for 2 years. We need to wrap it up this year. And the care team will always here to support them to continue with that process. And VDDS will be available to support the GPs as well.
So will we know what happens?
Yeah,
after?
we'll know what happens at 12 months. That's what our evaluation, we've done all the qualitative evaluation with the GPs and all the training. So
Longer if there's a successful tapering off, is there going to be?
We don't have
Don't have the
capacity to
funding?
do long-term follow-up for this project. But given that they've tolerated, so 6 out of 9 have tolerated the reduction very well so far, even if they can't come off all of their psychotropic medications, that's still very positive for the person.
Okay. And is there one more? Is there a plan for a larger scale study?
We definitely hope that anyone here would be happy to scale this up, and feel free to contact me to discuss. Yeah, okay. Yeah, definitely happy to discuss. It would be great to see this scaled up. Yeah.
One more, and you already put your hand up, so I'm going to hand it over to you.
Hi. Thanks. No, my thing was just, I guess, greater recognition for parents, because there's a lot of fear around this as well. They're the biggest barrier, because I've seen significant behaviors, and then you try to say, hey, look, I mean, I've tried in fade outs, and they're like, no, I don't want to go back to that, but just heavy supports for parents. Yeah.
Yeah, absolutely. And it was really great when we had the session and 3 mums could come along just to hear about their experiences. But also when we were running through all the different side effects for all the medications, 2 of the mums actually made connections with what they've seen in their child with the side effects, that they've never made that connection before as well. So, parents and carers, they're not really well versed on the harms that the medications are causing. Everyone just assumes that if it's prescribed, it must be beneficial. So I think to help with those discussions, if you're already noticing harms, and that could be as subtle as not participating fully during day programs, or, napping a little bit more than usual, to really highlight that to the parents to help give it a try. And, we definitely reinforce that it's just a trial. If things don't go well, we've still got other options available. So that did help with the discussion a little bit, but the 2 mums were very alarmed at the side effects, and it's mostly to do with the movement disorders with some of the oldest antipsychotics prescribed from 20 years ago.
All right, Julie, you've got 30 seconds, all right? No, it's all right. I'm bringing it round because we're recording it.
Do you know if there's any initiatives at a state or national level that could be bringing communities of practice to be consultants, like the dual disability cohort? Because one of the things that's lacking already in the sector is physicians who understand, have the time, and clients that can actually access those services. A lot of this seems to be really great initiatives that I think could be supported at a state or national level by virtual services consulting, providing advice to those people on the ground that are interested and trying to do the right thing, but trying to connect the specialists together.
Yeah, absolutely. I think that's one of the Royal Commission recommendations. I think New South Wales does have a service. I think they're the only jurisdiction that does. Our statewide service, their capacity is very limited. So we're constantly lobbying, not lobbying, but trying to speak to our colleagues at Department of Health to have those discussions. I think everyone is aware that it's a massive service gap. But yeah, other than that, I think every jurisdiction's at different stages. And unfortunately, you know, in Victoria, we don't have a service where clinicians can just call up for some advice. Yeah.